IES for giving me this opportunity to talk about seizure semiology and EEG in temporal lobe epilepsy. What is the value of this semiology and EEG? And there are certain limitations in localization of the epileptogenic zone. So epilepsy surgery, all of us know, is an important treatment option in patients with drug refractory epilepsy. The ability of the success of epilepsy surgery depends on the ability for precise localization of the epileptogenic zone, and seizure semiology represents the main symptomatogenic zone, and it is the most important part of the pre-surgical evaluation. And during the interpretation of the seizure semiology, we should know what is the latest terminology. Previously, the partial seizures, we call them as focal seizures. The simple partial seizures are now known as focal aware seizures. If there is motor movement, we call it as focal motor aware seizures. If it is complex partial seizures, now we do not use the term complex partial and use the word focal impaired awareness seizures. And those which are secondary generalized seizures, now we call them as focal to bilateral tonic-clonic seizures. And whenever before we analyze the semiology in temporal lobe epilepsy, always we should have information about the clinical variables. What are the important variables? Is there any history of febrile convulsions, which is seen in more than 30% of the people with temporal lobe epilepsy? Sometimes childhood CNS infections or even trauma can lead to hippocampal sclerosis or a temporal lobe injury. Age at onset of the epilepsy, usually the unprovoked seizures start somewhere in the first decade. What is the frequency of secondary bilateral tonic-clonic seizures, which are usually infrequent in mesial temporal lobe epilepsy? And also, very important is the initial ictal symptoms like epigastric rising sensation or any autonomic symptoms, affective or emotional symptoms, any dreamy states, sensory illusions or hallucinations, which are more with lateral or neocortical temporal lobe epilepsies, not with the mesial temporal lobe. In addition, in the history, we should take ictal signs, which are early or late. Early means within the beginning or first half of the seizure. Late is usually after 20 seconds. The ictal signs like oro-elementary automatisms, upper or lower limb automatisms, non-verbal, verbal automatisms. I'll come to that, what they mean and how do we interpret in the semiology. We also take history about head and eye deviation, whether it is early or late, any tonic posturing of the limbs, facial expressions. Verbal automatisms is nothing but ictal speech, where we define it as ictal production of understandable stereotyped words or phrases for which the patient is amnestic. She doesn't know what she has spoken. Vocalization means there is either moaning sound, groaning sound, howling sound, or humming. These are stereotyped vocal non-verbal automatisms. So any sounds, we call them as non-verbal automatisms. Verbal automatisms is understandable stereotyped speech. The initial first 10 seconds of the seizures are very important for early signs. And you should also take history about the secondary loss of contact, that is absence of non-stereotyped reaction to any visual, motor, verbal or sensory stimulus. Also keep a note about the seizure duration. Usually temporal lobe seizures are prolonged when compared to frontal, which are usually brief. In addition, we should take history about any post-ictal deficits like any post-ictal aphasia or dysphasia common with left temporal lobe, or confusional state, amnesia, and sometimes even post-ictal psychosis state. Normally, whenever the temporal lobe seizures do happen, the propagation of the temporal lobe seizures is responsible for the seizure semiology. Normally, the temporal lobe seizures start from one side and then go to ipsilateral frontal lobe, especially the mesial frontal. Then they go to contralateral frontal lobe. So they go to the frontal lobe through the basal ganglia. And then from the ipsilateral to the contralateral frontal lobe, then it comes to contralateral temporal lobe. And that's why the seizure semiology depends on this propagation pathway at various times after the ictal onset. So whenever during the pre-surgical evaluation, what are we looking for in temporal lobe epilepsy? Normally, our aim is to know where is the seizure starting from. For example, if you have a hippocampal sclerosis, as seen marked by the left, actually this is just an example. In the hippocampus, if there is a lesional zone, we say that is lesional zone. But lesional zone is not equal to ictal onset zone. So resection of the lesion will not always give you seizure freedom. And all around the lesion, including the lesion and surrounding part, will have the so-called irritative zone. This is represented by the interictal spikes, which are seen as the temporal spikes in our interictal EEG. In addition, there is a symptomatogenic zone that is spread to the lateral temporal lobe as well as to the basal ganglia, resulting in the symptoms. And then functional deficit zone that is spreading to the basal ganglia and sometimes later to the motor cortex, can cause a paresis of a limb or transient weakness. That is the functional deficit zone. But however, the epileptogenic zone is the one which includes the lesional zone, irritative zone, symptomatogenic zone, and sometimes even part of the functional deficit zone. So it is important to resect this entire epileptogenic zone to have maximum chances of seizure freedom. So the idea of pre-surgical evaluation, of which the seizure semiology is a very important part, is to identify this epileptogenic zone. So coming to the semiology in temporal lobe epilepsy, what is semiology? It has to be the first or one of the earlier components of seizures in order to have a localizing value. So it is the onset which is very important. Even in the videos which the patient's families get it, it's more important to take a good history rather than looking at the seizure, because sometimes it's very difficult to capture the seizure at the onset, and most of the time we see the semiology either in the mid or late part of the seizures. The later symptoms or signs are usually due to propagation, and they will have only a lateralizing value. They will not have a clear-cut localizing value. The semiology, whenever we are analyzing in temporal lobe epilepsy, it helps for either to say whether it is coming from the right hemisphere or from the left hemisphere, whether it is localization, that is temporal or extratemporal, which can be again frontal, parietal, or occipital. And then for sublobar localization, so can we differentiate into mesial temporal, lateral temporal? Sometimes it's a mesial and lateral temporal. So now we'll go into the important aspects of the seizure semiology. So whenever we are analyzing the seizure semiology, once the seizures are recorded, what do we really analyze? First, the clinical and EEG correlation should always be there. That is, whatever you have taken in the history, the semiology should match the habitual seizures. And we should view the semiology independent of the ictal EEG. So first we should see the entire semiology, make a note of all the signs, try to lateralize and localize, and then see the ictal EEG onsets. You look at the pre-ictal, ictal, post-ictal aspects of the semiology. Pre-ictal means, is there any premonition or an aura? Ictal, that is at the onset. Post-ictal is sometimes there are important signs. Read each seizure independent of other. For example, you have recorded 3 or 5 seizures. Everything may not be stereotyped, but still it represents the temporal lobe semiology, and all the signs may not be present in every seizure. So we should take a combination of all this to decide about lateralization and localization. Always show the seizure once recorded to the caregiver and confirm that these are the habitual seizures, because most of the times we stop the anti-seizure medications in the video EEG lab, and patients may develop a secondary bilateral tonic-clonic seizures very fast. That's why the reduction of the anti-seizure medication should be the day 1 you give 70% of the dose. That is, you reduce only 30%. Day 2 you give 50% of the dose, and day 3 you stop, so that you try to record the habitual seizures in the initial days. And also look at the chronology of the seizure, evolution and termination. And also whether they are recorded in single or clusters. Usually temporal lobe seizures you record singly, whereas clusters means one after another typically occurs in extratemporal lobe epilepsies. The more important thing is, based on the semiology, we should be able to differentiate temporal from frontal lobe seizures. Temporal lobe seizures are usually less frequent, 1 to 2 per month. The onset of the seizure is slow, even evolution is slow. It is not less common in sleep, and also it progresses slowly. There are automatisms which are very frequent. Hypomotor seizures with staring is more common with temporal lobe seizures. Hypermotor behaviors, bipedal automatisms are rare, but nowadays they are well described in temporopolar seizures because of spread to the frontal lobe. Vocalizations, ictal speech is common. Secondary generalizations are less common even when you stop the medications in the video EEG lab. The post-ictal aphasia occurs when the seizures are coming from the dominant hemisphere. In contrast, the frontal lobe seizures are usually very frequent daily or weekly with an abrupt onset, short duration, abrupt offset, and automatisms are less common. And then hypermotor element is common, where there is vigorous bipedal as well as cycling movement sometimes. The duration of the seizures are brief with clustering, that is many seizures occurring one by one at a time, predominantly in sleep. Then, coming to the analysis of the seizure semiology. In temporal lobe epilepsy or any seizures, we look at first the aura. What are the motor manifestations? Are there any sensory phenomena? This we have to ask the patient, and also look for any autonomic symptoms, either in the form of sweating, piloerection, or any heart rate also should always be ECG lead should be there. In the postictal phase, we look for any postictal aphasia or postictal nose swiping. Aura is seen in 30% of the cases of temporal lobe epilepsies, usually in the form of fear, olfactory aura, epigastric aura. So immediately after every seizure, the technologist who is always there should ask, did you feel anything before the seizure? The motor manifestations can be either single or in cluster, as we discussed. And the idea of motor manifestations is mainly for lateralization rather than localization, and also for any language lateralization, that is coming from the left or right temporal lobe. How do we lateralize based on the semiology? There are signs based on which we say that the seizures are localized to ipsilateral hemisphere or contralateral hemisphere, whether the semiology signs are suggestive of language non-dominant hemisphere involvement or dominant hemisphere involvement. What are the lateralizing or localizing signs in temporal lobe epilepsy? If there is head deviation or eye deviation or both, you look for that. And also you look for unilateral tonic or dystonic posturing, and you look for any weakness of a limb. So we'll come to the localization of these. Then you look for language signs in the form of, during the seizure, any aphasia or total speech arrest or verbalization of coherent speech. That means it is ictal speech. So how do we lateralize these signs? In the postictal phase, we look for postictal aphasia, any motor weakness. In addition, we look for ictal vomiting, unilateral eye blinking, ictal automatisms with preserved consciousness, nose swiping at the end, that is post-ictal nose swiping. So now, how do we lateralize these signs? Usually, if early head and eye deviation, early means within the first 5 to 10 seconds, it lateralizes to ipsilateral hemisphere. Whereas late head and eye deviation, that is before secondary generalization, it lateralizes to contralateral hemisphere. Similarly, if there are automatisms of one limb, usually they are ipsilateral. That is, if you have a right hippocampal sclerosis, most of the times you get a right hand automatism. But the sensitivity of this is only 30 to 40%. Unilateral eye blinking is ipsilateral sign. Again, post-ictal nose swiping, where the patient just wipes the nose with one hand immediately after the seizure, it has an ipsilateral lateralization. The others, if somebody has dystonic limb, usually it has a contralateral lateralization. That is, for example, if you have right hippocampal sclerosis, the left hand will be immobile, the left hand will be weak, and then late head and eye deviation will occur. And if there is asymmetric tonic limb posturing, I will show all these signs in the next seizures when we are recording. That is figure of 4, where the lateralization will be opposite to the hand, which is extended. Then there are certain signs. Again, we discuss based on the dominant, non-dominance. Usually, most of the time, non-dominant means right side. So, what are the signs which are in the semiology suggestive of non-dominant or right hemisphere? Ictal speech, ictal vomiting, any gastrointestinal symptoms are usually non-dominant. Ictal smiling, spitting. Though fear can occur on either side, more common with the right side. Ictal cough, ictal automatisms, especially on the right hand, post-ictal nose swiping are common with non-dominant hemispheres. The dominant hemisphere can be associated with a speech arrest, post-ictal prolonged dysphasia for about few minutes to sometimes half an hour, and ATLPs are more common with left-sided, though it can occur sometimes with the right side. So what is the sensitivity and specificity of these signs? Whatever marked in red are highly specific. If somebody has forced head deviation before secondary generalization, 90% specific. Figure of 4 posturing is highly specific. Unilateral dystonic hand is specific. And ictal automatisms with preserved consciousness, such as non-dominant temporal lobe, again 99%. Ictal post-ictal aphasia, 99%. Post-ictal weakness, again 99%. All the other signs have a sensitivity, specificity of around 70 to 80%. Then how do you differentiate the hypomotor seizures of temporal versus extratemporal? Temporal are usually slow evolution with a motionless stare or hypomotor seizures, oro-elementary automatisms, ipsilateral limb automatisms, contralateral dystonic limb posturing, more than 1 minute, infrequent secondary generalization, and ictal speech. These are so-called mesial temporal lobe epilepsy. Whereas the lateral temporal lobe or neocortical or extratemporal, there is a rapid evolution with hypermotor elements, frantic behavior, vocalization, secondary generalization is very frequent. So we'll start with a typical temporal lobe seizure. Can you see the video, please, Sangeeta?
Yes.
We can see video.
Yes, if you see, the patient started. So he is having oro-elementary automatisms. Left hand dystonic. He is following commands and staring. Right hand automatisms, left hand dystonia. Now late in the event, not following the command. Now you can see left face jerking. And gradual deviation of the eyes towards the left. Bilateral eye blinking, then jerking of the left face and the head. So there is oro-elementary automatisms at the beginning, partially preserved awareness at the beginning because he was following commands. He had right upper limb automatisms. He had left upper limb dystonia, late eye and head deviation towards the left. So our lateralization is right. This patient had right hippocampal sclerosis and was operated almost 10 years back. In contrast, if you see this seizure, so she's just sitting and talking to her daughter. So she started with motor restlessness with violent movements of both the lower limbs and in the tongue, rolling in the bed, again bipedal movements. So sometimes this can be mistaken for a pseudo seizure. So this is a typical frontal lobe seizure or a hyperkinetic or hypermotor seizures. And now the seizure is over and she is in the postictal phase. So that is the difference between a temporal versus an extratemporal or a frontal lobe seizure. Now we'll see what are the signs in case of temporal lobe seizures. So we'll start with the intense fear in this. You please observe along with left hand dystonia. So she calls the mother with intense fear. You can see the left hand is dystonic or immobile. Some oro-elementary automatisms. So she has intense fear, left upper limb dystonia, right upper limb automatisms. She's confused and amnestic for the event, and she had a very clear-cut right hippocampal sclerosis. So these are all operated cases. Actually, these patients will have excellent response post surgery. Now you keep seeing the patient. This is another patient. He is watching the TV. So sometimes it's very difficult to say when the seizure has started, especially when there is a behavioral arrest in a person who is sitting silent. So possibly he is having behavioral arrest. That's why it's very important to see the EEG corresponding whether there is any ictal activity. So he started with now bilateral automatisms more on the left side. That is complex rapid automatisms. And he is having even oro-elementary automatisms, left hand automatisms. The right is immobile. He continues to have left hand automatisms. Right hand is dystonic now. He's wiping his face the moment it's given. So he continues to have right hand dystonic posturing. So in this, the patient had a prolonged hypomotor phase, left hand automatisms, oro-elementary and right upper limb dystonia. So this is a case of left hippocampal sclerosis. Even this patient was operated. Next, we'll see another young lady who was evaluated. So by repeatedly seeing the same semiology, we reinforce the understanding. So I'm showing this. So now what's happening? Left hand automatisms. Even right hand, there is some automatisms. The left hand has gone into an immobile state. She continues to have right hand automatism. Sometimes automatisms can be bilateral. That's why we give more importance to dystonia. So continues to have left hand dystonia and she continues to have right hand automatisms with some rotatory movements. So normally during this time, if somebody is there, we should do response testing. Now late in the event, she is having deviation of the left face tonic contraction. And then continues to have bilateral staring confusion followed by head and eyes went to the left, bilateral eye blinking, jerking off the left upper limb now. Eyes and head went to the left side. And she continues to have jerking of the left upper limb. So this is a right hemispheric lateralization with right. She had again right hippocampal sclerosis. Now it is going into secondary generalization with tonic extension of both the lower limbs. And she continues to have the jerking. And if you keep observing, the last jerk occurs in the right upper limb late in the event. So ipsilateral late jerking is again an ipsilateral sign. That is because the contralateral side, the hand and leg are weak. So they stop jerking and the ipsilateral limb continues to have the jerking. So sometimes to avoid a secondary generalization, we have to give a brief midazolam, low dose midazolam, so that. So now if you see, the left side has stopped jerking and right side continues to jerk. That is last jerking occurring on the right side. Even the right lower limb is jerking. Right hand and right lower limb is jerking. So finally, this is a right hemispheric lateralization with right temporal localization. Now we'll see what is figure of 4 posturing. If you see in this video, initially patient will have behavioral arrest followed by secondary generalization with figure of 4 posturing with extension of the right upper limb, flexion of the left upper limb. So this is a girl who has a cavernoma on the left side. So now she's calling actually. She will call the parents that with an aura. So she's calling. And continues to have. So possibly that's an aura. And now she is having behavioral arrest where she is staring continuously for almost 10 to 15 seconds. Now you keep observing. She had head and eye deviation towards the right with figure of 4 posturing where there is extension of the left upper limb, right upper limb along with flexion of the left upper limb. So very clear cut. So the lateralization is opposite to the side of the hand which is extended. So right hand is extended. So after that there is secondary generalization. That is figure of 4 posturing. And this is her MRI. Again, this lady was also operated almost a decade back. Then sometimes ictal teeth grinding can occur during a temporal lobe. It is temporal lobe localization, either right or left. If you see this, we can hear the sound.
Sita,
It's
for some
grinding the
reason,
teeth.
Sita, the sounds, I don't know if everybody, Sangeeta, are you able to hear the sounds of the video?
I can hear the sound, but not the video sound, I think.
So, Sita, your sound is coming, but your video may testing and this that sound, no, it's not coming.
Others are not coming. Yeah?
No, that bruxism also we couldn't hear, but
okay.
Maybe.
Fine. So how to do that?
Is there any issue? Mr. Mohit? Her video sounds are not coming. I don't know. You carry on.
That's better. Yeah, otherwise, no. It's okay. Most of
Yeah,
them are
you
fine.
are describing it, so
Okay.
that's okay even if you can't.
Yeah, in this, the patient has teeth grinding along with left upper limb dystonia and right upper limb automatism. So it is ictal teeth grinding, which is a localizing sign for temporal lobe, but not lateralizing to right or left temporal lobe. Actually, this is very interesting. This is an ictal singing. So you can see now he starts vocalizing.
Mr. Mohit, why are the sounds coming?
That's okay. Fine. So this patient has a clear-cut right hippocampal sclerosis and he is very well controlled. So, no, maybe we have to do something with the share sound.
No, but
okay. Now
in that share video, there will be one optimized video, no?
Can you hear now?
Yeah,
okay, then I will just show the bruxism for a few seconds. Can you hear the sound?
Yeah, now we can hear very nicely. It's scary.
You can see the left hand is immobile, he is hypomotor, not responding after bruxism. So now I will show another interesting. Ictal singing is usually non-dominant. So this guy just, it's one of the routine cases while doing in the lab, we got it and is very well controlled with just carbon. And he is amnesic for this, and it is nothing but a non-verbal automatism, non-verbal automatism, I will say. So again, it is non-dominant temporal. Next, we'll go to ictal vomiting. This is a young girl. She has a right temporal FCD, focal cortical dysplasia, with the propagation towards the occipital lobe. So her symptoms are also similar, and she gets a severe nausea along with the vomiting sensation. Again, she was operated almost 8 years ago, and she's free. She is pressing, maybe she has some sensation, pressing the event button. Unpleasant expression on the face. So she says she has severe nausea. After that, head and identification. Yes, intense fear which she remembers during the event along with this. With vocalization. And she remembers the questions which are asked during the event, though she cannot talk. So now it is secondary generalization later in the event with extension of the left upper limb, flexion of the right upper limb. Again, something like a figure of 4. Now you can see this is again extension of the left, flexion of the right upper limb. So this was a clear-cut right hemispheric lateralization because she had significant nausea, deviation of the eyes and head towards the left side, figure of 4 posturing with extension of the left upper limb. Now we'll see another important sign, unilateral eye blinking. So usually this is because of the temporo-peri-insular networks. So this girl has a lesion actually not in the temporal lobe but in the peri-insular region. So she continues to have unilateral eye blinking on the right side, which is partially controlled with carbamazepine, and because it's not disabling, she refused to increase the doses and managing like this because she gets intermittently the eye blinking unilaterally on the right side. So remember that whenever somebody has unilateral eye blinking, it has a ipsilateral localization. Finally, we'll see the rhythmic ictal non-clonic hand movements, which is a specific automatisms. It has contractions. Normally, when to say rinch, it should be preceded or followed by dystonia of the hand. So this patient again, right hemispheric, right temporal epilepsy. You keep watching. He opens the eyes. He'll be staring. He opened the eyes from sleep, staring. Then he will develop the rinch, that is rhythmic ictal non-clonic movements of the left hand. Now you see his left hand starts moving. See this left hand. Right hand may be an automatism. And he continues to do these movements. Then it is going into an immobile posture followed by a dystonic posturing of the hand. He continues to have right hand automatisms, suggestive of right mesial temporal or right temporal localization. Then he gets up. Possibly it is spreading to the frontal lobe now. Dystonia is due to basal ganglionic involvement. Then now he becomes very restless. He develops ambulatory automatisms where he will not sit in one place, gets up, keep walking. So this is ambulatory automatisms. So here again the lateralization is right temporal lobe. So to sum up regarding the semiology before we go for the ictal EEG, in case of mesial temporal lobe epilepsy, we should remember that there are 4 A's. That is, the patient will have a clear-cut aura of either fear, epigastric rising, nausea, and arrest, that is hypomotor element. They will have automatisms and most of the time amnesic for the event. epigastric aura with motionless stare with early oroelementary automatisms, contralateral dystonic posturing with ipsilateral limb automatisms, rare secondary generalization. In neocortical temporal lobe or lateral temporal lobe epilepsy, usually they will have auditory or cephalic auras or undiscernible, where they cannot explain, with complex automatisms early in the event, vocalization, gross truncal movements, and secondary generalization is frequent. But normally, it may start, most of the time, the lesions can be either mesial or lateral or sometimes involving the both. So, in mesial temporal lobe epilepsy, as I already said, initial epigastric sensation, fear, delayed oroelementary or elementary upper limb automatisms with loss of contact late in the event with the surroundings, long seizure duration, absent or rare bilateral tonic-clonic. In case of lateral, auditory illusions or hallucinations, loss of contact, shorter duration, and more frequent. But if there is mesiolateral, you have a combination of these features. And if there is hippocampal involvement, leads to behavioral arrest. Insula amygdala is responsible for the epigastric aura. Opercular involvement, that is the perisylvian region, due to oroelementary automatisms. Basal ganglia involvement is responsible for the dystonia of the contralateral limb. Spread to the supplementary motor area leads to asymmetric tonic limb posturing, that is the figure of 4, and spread to the primary motor cortex leads to tonic-clonic movements with clonic jerks. So that's it. That's about the semiology in temporal lobe epilepsy. Shall I go ahead with EEG? So next 10-15 minutes, I'll talk about the how do you interpret after looking at the semiology. You look at the interictal and ictal EEG in temporal lobe epilepsy. The interictal EEG in temporal lobe epilepsy, if you do short recordings, it can be normal, but most of the times when you do pre-surgical evaluation, it will be definitely abnormal. It can have non-specific changes like slow background activity, regional slow activity in the temporal region, or generalized slow activity can be present. And the epileptiform activity is usually in the form of either interictal or ictal epileptiform discharges. Most of the time, one should be careful in the short recordings about the RMTD, or rhythmic mid-temporal theta of drowsiness, which should not be interpreted as cases of temporal lobe slowing. So coming to, this is a case of right hippocampal sclerosis, where we are seeing rhythmic around 4 Hertz theta rhythm in the left blue. In all my EEGs, blue is left side. So in the left anterior and mid-temporal region. So this is called as TIRDA because it is rhythmic delta. If it is polymorphic, you call it as TIPDA. In patients with mesial temporal lobe epilepsy, 90% will have this, and 85% will have clear-cut spikes. The rest of them, we call them as oligospikers, where we do not see the spikes. And it has a high lateralizing value. In temporal lobe epilepsy, the specificity of interictal discharges, sensitivity is 70%. Usually, they are in the anterior and mid-temporal leads. And sometimes we can have bilateral independent or bitemporal spikes because of the spread of the discharges through the interhippocampal commissure. This is a case of clear-cut left hippocampal sclerosis. But we are seeing right anterior mid-temporal as well as left anterior mid-temporal spikes. Normally, in such cases, we do a spike counting. Usually, in our lab, we do 6 hours awake and 6 hours sleep spike counting just before the first seizure. So, in this, normally we count right is to left. Normally, you have automatically the moment you do the spike counting, there are softwares where it gets converted. The ratio should be at least 70:30 to say that it has an ipsilateral lateralization to have a good outcome. Though we still operate patients who have bitemporal IEDs, but with unitemporal ictal EEG onset. The localizing lateralizing value is unilateral interictal epileptiform discharges predict ipsilateral seizure onset in almost 90% of the cases. Whereas bilateral IEDs, with unilateral seizure onset is seen in 50%. This is one of the oldest studies done in 1990s. Then we will go to the real part of analysis of the ictal EEG patterns in temporal lobe epilepsy. Whenever we are looking at the ictal EEGs, what are the things we look at? One is localization. That is whether it is anterior temporal, mid-temporal, or hemispheric, or it is bitemporal. Morphology. Morphology means whether it is alpha rhythm, theta rhythm, delta rhythm. Time course means when it starts, how the rhythm starts, how it evolves in the first 30 seconds after the onset of the seizures. Any post-ictal changes, that is sometimes the ictal onset may not be clear, but post-ictally you can have focal spiking in a particular area or slowing. Then finally, lateralization, localization, accuracy is determined. So what are the EEG ictal patterns for localization? What are the terms we use? Focal. Focal means it's confined to a single single electrode region that is confined only to T3 or even T1 or T4. Regional means temporal rhythm, that is anterior and mid-temporal. Lateralized to one hemisphere means it is frontotemporal, you call it as one hemisphere, or entire hemispheric, that is fronto-temporoparieto-occipital. Bilateral means it is lateralized to one hemisphere. Means you are seeing the discharges bilaterally, but more amplitude predominant as well as well formed on one side. Bilateral, non-lateralized. For example, bilateral frontotemporal, then you will say non-lateralized. So for this, the difference between those regions should be at least more than 2:1. So we'll see some examples. So this is an example of a focal rhythm. Normally, we don't see focal rhythms in the surface called PEG. Most of the time, we see this in intracranial recordings. So this is most of the time, what we see is a regional ictal EEG onset in temporal lobe epilepsy. Here we are seeing left anterior and mid-temporal. That is, it is confined to F7, T3. That is 2 electrodes. That is the temporal. Actually, there is nothing in the T5. So anything which is anterior mid-temporal ictal EEG onset in a temporal lobe has an excellent prognosis. What is lateralized rhythm? If you see in the right hemisphere, you are seeing both in the frontotemporal parieto-occipital region, but in this, the maximum amplitude, that is maximum surface negativity, is happening at the F8. So still, this is one of the temporal rhythms at the onset, which may again evolve within the first 30 seconds as a very clear-cut focal rhythm. We'll see the EEGs. Then what is bilateral? Here, if you see, there is bilateral frontotemporal rhythm. So there is no clear-cut lateralization. So we call it as bilateral temporal onset. So the EEG at onset is important. EEG at evolution is also important. In temporal lobe epilepsy, the onset may not be clear-cut in some cases, but evolution within the 30 seconds has the, if it is confined to the side of the lesion, then the prognosis is very good. So then what is the morphology? Morphology can be in the form of at the onset, alpha, theta, delta rhythm, or it can be paroxysmal fast activity, or there can be only attenuation at the onset, or there can be rhythmic spiking. So how do you look at this? If you see here, this is the ictal EEG onset, but you see it's coming from the right side, a little posterior, but definitely this is a fast alpha rhythm. Next is theta. This is now most of the time we see a theta which is around 5 to 8 hertz. You can see excellent theta coming from the right side. Actually, here it is coming in the anterior leads. Then delta rhythm. Delta rhythm you can see on the left frontotemporal chain. There is a delta rhythm of 3 hertz at the onset. Then beta rhythms are usually seen in frontal lobe epilepsies, where you can see frontal beta, but well formed on the left side. But this beta rhythm may be seen in temporal lobe epilepsy if there is a focal cortical dysplasia at times. Then what is attenuation? So before the automatisms with chewing started, we can see normal alpha activity in the background with sudden attenuation of the background for about 2 seconds. You call it as generalized attenuation at the onset. Sometimes you can have a rhythmic spiking as seen is in the left side, but here it is well formed in the posterior leads. Then arrhythmic mixed frequency means at the beginning there is a theta rhythm intermixed with artifacts evolving into a nice theta rhythm at the later, or sometimes you have a mixture of delta as well as theta at the beginning, which you call it as arrhythmic mixed frequency. Then we look at evolution. Evolution is nothing but increase in the amplitude and frequency of the discharge, which with showing a propagation with increase of spatial propagation. Based on this, if the clear-cut onset present at the beginning, you call it as pattern at onset. Sometimes you may not see at the beginning, but see later within the first 30 seconds, you call it as later significant pattern. So we'll see some examples of this. If you see in this patient, this is pattern at onset. This is the left hippocampal sclerosis. We can see nice initially delta rhythm evolving as a theta rhythm and evolves very well in the left anterior mid-temporal leads and partly to the left hemisphere. So you call it as pattern at onset, rhythmic theta activity. This is a regional left temporal rhythm. Whereas later significant pattern, if you see here at the beginning, there are chewing artifacts. It's not very clear at the beginning, but later if you see within the first next 10 seconds, there is a good evolution in the theta rhythm on the left side. So you call it as rhythmic theta at onset, regional left temporal ictal onset, which is a later significant pattern. Then if you see this here, it is a rhythmic theta, which is seen on both the sides. Amplitude is little more on the left side, but this is non-lateralized. So you are not sure whether it is to the right or the left side. So it's important in temporal lobe, more important is to have a lateralization than for localization. Localization is possible in up to 2/3 of the patients. In others, it can be lateralizing. Rarely false lateralization also can occur in a condition called burnt out hippocampal sclerosis, where there is a contralateral spread of the ictal EEG. So Ebersole and Pescia in 1996 has given a description of the early, most of the time, the classical pattern, which comes from the mesial temporal lobe in hippocampal sclerosis, is a type 1 rhythm, where you see a nice theta rhythm at the onset or within first 30 seconds. Whereas type 2 and type 3 occur in temporal neocortex or the lateral temporal lobe epilepsy, where you don't onset in the anterior mid-temporal, but you see in the frontocentral leads. So we'll see some examples of mesial versus lateral temporal lobe. So type 1, A means this is, I am showing sequential pages of the EEG. Here the EEG is normal. You can see that there is a right frontocentral as well as mild anterior temporal rhythm which has started, which evolves on the right side for in the next 10 seconds, including in the right anterior temporal chain, but mostly in the frontotemporal. This is F8, T2, T4, and also then F4. So in the temporal lobe, followed by spread towards the left side. So this is a typical onset. Whereas type 1B, where initially you may not see, but evolves at a later date. If you see here, actually in the last second, it started on the right side again. Then it is seen bilaterally evolving, but again, the amplitude is well formed on the right side. That is 1B rhythm. Whereas in 1C, usually there is a frontocentral onset. If you can see on the left, frontocentral onset, though some rhythm is seen on the right side. And then it evolves very well on the left side late in the event. So this is frontocentral pattern followed by evolution in the anterior mid-temporal leads. In type 2 rhythm, again, so it's very, what is important is the pattern at onset, late significant pattern are more common with the hippocampal onsets, whereas ictal spiking, slowing are more common with lateral temporal patterns. So nowadays we don't follow this Ebersole patterns, though these were described. This is again type 2 rhythm. You can see this is neocortical temporal. Anything type 2, 3 are neocortical. You can see that there is so much of slowing, means rhythmic theta is seen. Actually, it is seen on both the sides, and then it settles well on the left side with a posterior amplitude predominance with maximum negativity of, occurring at T5. Whereas this is another case where you can see there is a spiking occurring at the onset. So this is possibly the propagation is going towards the temporo-occipital or posterior temporal cortex. So we are seeing rhythmic spiking at the onset. After that, there is a left temporal rhythmic theta which is happening. So here the substrate can be either a focal cortical dysplasia because there is a spiking. Normally in hippocampal sclerosis, we do not see ictal spiking at the onset. This is another where there are bitemporal spikes occurring. That is called pre-ictal potentiation of the spikes before the seizure. And there is you can see that there is a left frontotemporal slowing followed by increase in the amplitude and frequency with evolution of the rhythm and secondary generalization. So what is the importance of these patterns? Type 1 pattern is highly specific for seizures from the hippocampus. Type 1 patterns are never seen in neocortical or lateral temporal lobe epilepsy. Type 2 patterns and 3 patterns are seen in neocortical temporal lobe epilepsies. So how do you identify this? In case of rhythmic theta at onset is seen in 80% of mesial temporal lobe epilepsies. And 58% of neocortical and never seen in that is frontal lobe and other extratemporal lobe epilepsies. Repetitive spikes are never seen in mesial temporal lobe epilepsy, especially except when the focal cortical dysplasia is the substrate. Paroxysmal fast activity is never seen in mesial temporal lobe epilepsy, more with frontal or other extratemporal. So the common pattern in mesial temporal lobe epilepsy is a focal localized pattern. Neocortical lateralized, that is, it's like that hemisphere is affected. Extratemporal, most of the times it may be a generalized onset at the beginning, followed by some evolution. So what are the pitfalls of an ictal EEG? No discernible ictal rhythm may be seen in up to 10% of the cases. Diffuse ictal EEG onsets may be seen, especially in neocortical temporal lobe epilepsies. Contralateral ictal EEG onsets occurs in vested hippocampus syndrome. Bilateral hippocampus sclerosis, if it is present, the rhythm may be bilateral or unilateral or predominantly unilateral ictal EEG onset with bilateral in some seizures. So one should be careful to differentiate mesial temporal from lateral temporal, which have slow, unstable, changing rhythms, or fast rhythms, or more diffuse rhythms. So this is just one of the studies by Foldevery, which all of us most of the time take it as a guidance for all these ictal rhythms. Again, as I already said, mesial temporal lobe epilepsy is associated with a good localization in 93%, whereas neocortical temporal lobe in 74% of the cases. So finally, to summarize, what is the present role of ictal scalp EEG? The ictal scalp EEG is useful in seizure localization and lateralization. Rhythmic temporal theta at the onset is highly suggestive of mesial temporal lobe epilepsy. Lateralized polymorphic delta is usually neocortical. Polymorphic is neocortical. Rhythmic theta is mesial temporal. Mislocalization and lateralization is a major limitation. The scalp recording should never be used in isolation for pre-surgical evaluation. Always, for example, sometimes semiology will give clue in 2/3 of the patients. The EEG will give clue in about, again, 80% of the cases. When you combine both, the localization and lateralization is more than 95%. So we should use both as complementary to each other. So thank you. If any questions, we can discuss.
Yeah, thank you, Sita. I think it was very well covered, all the different semiologies as well as the ictal onset and everything. I don't think there are many questions about because you have explained everything quite well, I think. One question is that post-ictal spitting is associated with temporal lobe epilepsy, but background is normal. There's some from Mr. Sachin.
Yeah,
Hello?
so what I think he's asking, when they're spitting, post-ictal spitting, why is the EEG, should the EEG be epileptiform or can it be normal or can it show
Normally,
slowing?
it is ictal spitting, which has more localizing value to the temporal lobe, and usually it is non-dominant temporal lobe. Post-ictal spitting may be because of excess salivation, because there is stimulation of the amygdala and periinsular area, which can cause excessive salivation, and patient can spit it later. So post-ictal spitting has no significant lateralizing or localizing value. It can only suggest that it is possibly spread to the periinsular region. Ictal spitting has a lateralizing value to non-dominant hemisphere.
And I think there's a second question is, what is cephalic aura?
Means they feel something in the head, which is very difficult for them to explain that. They will say something happening in my head.
Right, right. I think one thing important, what, no other question, no, Manjri, I think. Yeah, there's one more. Madam, can metabolic seizures have some clue in the semiology?
Metabolic.
Metabolic seizures.
Metabolic, any clue in semiology?
Semiology.
See, metabolic commonly is hyponatremia, which usually presents with subtle seizures or non-convulsive seizures. There you have to look for some tremulousness in the limbs in a drowsy person, or you look at some nystagmoid jerks in the eyes, or some tongue movements, or subtle jerks like myoclonus in the limbs.
It's important to
Otherwise,
remember
you will
that.
not get, or most of the time, hypomotor seizures. They'll be just
Yeah, but
staring.
you can have metabolic and also have a focal seizures. You know, you often we try to think metabolic means generalized seizures. It's not like that. Often they may have a focal seizure and they may have a focal abnormality on the MRI also. So it is important.
Yeah, usually like Sangeeta said, hyperglycemia presents with focal jerking, which can be focal jerking, and they're totally aware. So they present with focal motor seizures in hyperglycemia, very common. Hypoglycemia also can present with focal seizures with some Todd's paresis. Most of the time they're interpreted as stroke related. So we should be very careful in deciding the management.
Right. Okay, the next question is, what is the difference between range and the usual automatism?
Yeah, so usual automatisms are in the form of semi-purposeful movements like mixing the atta or waving the hand in the air. Whereas in case of rhythmic movements is something like a tonic-clonic, but they are non-clonic. So you keep on doing a rhythmic movement. That's why you call it as rhythmic ictal, means during the seizure, non-clonic movements. And as I already said, it should be either preceded or followed by dystonia of the limb. Automatisms usually have ipsilateral lateralization, whereas Rinch has contralateral lateralization when we are analyzing the semiology of temporal lobe epilepsy.
So Rinch is a very faster movement compared to the automatism. Automatism is little slower. Rinch is quite faster.
Yes.
Yes. There is one more is how can we differentiate fragments from focal interictal discharges? From Mohammed Russell.
See, there is some terminology called fragmentation of the epileptiform discharges. This is typically described in idiopathic generalized epilepsies, typically juvenile myoclonic epilepsy, where you get bursts of generalized epileptiform discharges with intervals of normal background EEG or attenuated background EEG in between. So we use this in the context of those generalized epilepsy discharges. Whereas in focal interictal discharges, usually you will get focal discharges occurring. Usually for generalized, we use the term paroxysmal discharges. Whereas for focal, we call it as intermittent interictal anterior mid-temporal spike and sharp wave discharges. That is the terminology we use. So I hope that clarifies the doubt.
Yeah, I think one more person has asked that fencing posture or figure of 4 posture is described in frontal lobe seizure in Bradley supplementary motor area. That's correct. What she was showing was a spread from temporal lobe. When it goes to frontal, then you get this figure of 4 posturing. We are not
fencing is different. Fencing is 8. Yeah, what do you say, Manjari? Fencing is different from figure of 4.
So fencing is where the head and eyes are turned to an abducted and raised hand. So something like that. And figure of 4 is different from fencing.
Yeah, no, they are saying both of them are described in frontal lobe.
Okay.
And why are you putting it in?
So one thing here is that, you know, when you see the semiology, just seeing the semiology, you also have to see the sequence.
Spread from
what comes first and what comes second, what comes third. That is what Dr. Sangeeta is clearly saying. In temporal lobe, when it spreads to the SMA area, you will get figure of 4. That doesn't mean that the seizure is coming from the frontal lobe.
I think that Sita had shown a chart where it's showing from how it propagates. So according to the propagation, you will get the seizure semiology. Okay, the last question is, what is the ictal correlate of jerks in JME?
You get high amplitude spike and wave discharges or polyspike and wave discharges. If you put a EMG electrode, you will get a positive myoclonus. Positive myoclonus means you get a EMG activity followed by the polyspican wave discharges. In a negative myoclonus, which we see as in patients with SSP or something, during the jerk, you get a flat line in the EMG, followed by you get high amplitude, sharp and slow discharges in the EEG.
Right. Okay, there's one more question from Trilochan Babitra. When semiology and video EEG onset is temporal lobe epilepsy is suggestive of right or left-sided TLE, can we
No.
consider ATL without an MRI brain? Oh my God, no, no,
No, no, no, no.
No, no, no.
no, no, no.
Never.
All three of us
Never.
are saying no, no, no.
Never
MRI is the
compromise
key
on
for the outcomes.
investigations.
The MRI
Never.
abnormality must be there for any surgery to have the
Yeah.
best outcome.
And moreover, never remove a part of the brain which you can't fix back. Maybe after 30 years, you know, Trilochan will describe a technology by which you can join the brain back. But right now we can't do that.
No, no. Never compromise on this. You know, often it happens that you see a lesion and you want to operate, and when you do video EEG, it turns out to be that she has got pseudo seizures. So you don't know. So you must emphasize that do complete evaluation, then only, because it's a major surgery. You're removing part of the brain. You can't take it lightly, you know.
Yeah.
That's what I feel. Because it happens often. Surgeon tells, "Arey, lesion has seizure hai. Why you want to do video EEG?" But at least do an interictal, and they tell them to do a home mobile video of the what semiology is. At least that much you do, even if you can't do a prolonged ictal, you know. That much.
Yeah, but as of now, the standard of care is video EEG, and
yes,
I think
absolutely.
neurologists should make an effort to do video EEGs and open labs, because otherwise neurosurgeons are going to start doing it. And we lose that turf also.
No, no. Intervention, we are already going down. We should not leave
Yeah.
that.
So I think we can wind up, no?
Yes.
Yeah.
Sure.
So thank you all the ladies on Women's Day, especially Dr. Sita, Dr. Sangeeta, Dr. Samhita, all joined on the panel. Thank you so much. And I think Sita also showed a lot of colors on her EEG waveforms, pink, blue, red. So we celebrated Holi also.
And colorful
Nevertheless,
semiologies also, I think she showed.
yes, yes. So join us again next week is by Dr. Sangeeta, and I'd conclude by thanking LAR and NON for their unrestricted educational grant for holding this panel and EEG workshop. Sangeeta,
Thank
your
you.
words?
Yeah.
Sita, your words? Samhita?
Yeah, thank you. Thanks for the opportunity. Yeah.
Yeah. Thanks a lot, I think. See you next week.
Yeah. Hi, Samhita. Okay.
Okay.
Good night.
Yeah, hi, ma'am.
Bye.
Thanks a lot for that lovely elucidation.
Yeah.
And happy Women's Day to all the great women out
Yeah,
there.
Samhita,
Yeah.
happy Women's Day.
Same to you. Same.
Bye.
Yeah.
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 Bye.
Good night. Yeah. Bye.
Yeah, good night.